Okay, so we'll get started. So we are going to be talking about infections today, and we'll try to cover as much as possible. So we're going to first start with bacterial infections. So this is the first slide, and as you can see here, so I'm going to talk about the most relevant entities, the ones that are tested on your boards. So, so this slide shows you a nice subcorneal blister with a lot of neutrophils, and you can see easily that there are lots of bacterial colonies in there. So this is impetigo or bullous impetigo. Most of the biopsies done for impetigo are most often shaved biopsies. Subcorneal acantholysis can also be seen. So you can see discohesive cells. You may or you may not see the bacteria, but for a definitive diagnosis of impetigo, they have to show you bacterial colonies, and this is how they look like. So all of these are clusters of cocci bacterial colonies, so consistent with staph. So this is bullous impetigo. Let's go to our next slide. This is a gram stain, which is going to be illustrating those gram-positive cocci. So these gram stains, these will stain blue. So you can see the nice blue staining bacterial colonies on the top and over here. These are all the bacteria. Okay. The next bacterial entity, bacterial infection that we get tested on is, let's see, is a cornybacterial infection, which produces two infections, which is your pitted keratolysis and erythrasma. So Cornybacterium is again a gram-positive bacteria, and it is a filamentous bacteria. And on pitted keratolysis, which occurs on the palms and the soles of the feet, you basically get an invisible dermatosis on acral skin. On careful inspection of the cornified layer, this is not a very immunogenic bacteria, so it doesn't incite a whole lot of inflammatory response, but you can see that these organisms are present. They are beaded and filamentous. They kind of look better, bigger than your conventional bacteria, but smaller than tinea. These are gram-positive. They will stain with PAS stain as well, but it's largely the size and the beaded nature of the organisms that helps you to distinguish from tinea. So bigger than bacteria, but smaller than your conventional fungus. So this is a cornybacterium. So this is an example of pitted keratolysis. And the next few slides will show you erythrasma. So the same infection, but occurs in intertriginous sites. And what we can again see in here, this often comes in with an intertrigo-like impression. And again, not very inflammatory, so not very neutrophilic. But again, in the cornified layer, you can actually see in here these bacteria, which have kind of like a fungal morphology because they're kind of linear oriented and they are beaded. So this is all erythrasma. I'll show you another example. This one didn't scan really well. We'll go to the other one. Let's see the rescan slide. Okay, here. You can see here again the same, the fluffy bacterial colonies. In here, this is all erythrasma. Okay, stop me if you have any questions. Okay, the next one. The next common bacterial infection that we will talk about is syphilis. So syphilis, primary syphilis, presents with, again, a non-specific ulcer. Honestly, without a clinical impression, just by looking at the primary chancre of syphilis, it's difficult to say that this is syphilis. There are some clues. There is often prominent vascularity in the ulcer bed. The endothelial cells are pretty swollen. The most important finding that you're looking for is the presence of numerous plasma cells in the ulcer bed, as you can see in over here. So again, non-specific ulceration, prominent vessels with endothelial cells and plasma cells in the ulcer bed. If we were to do a stain, which would be your Treponema pallidum's immunostain, it would highlight the spirochete organisms. So this is again an ulcer. This is in the genital region. And it's the same thing. You can see that there are, all these prominent vessels with swollen endothelial cells in the ulcer bed. And there is quite a few number of plasma cells with neutrophils present in the ulcer bed. So that combination always makes you think about syphilis. Now, what are the stains that we like to see for syphilis is a treponema pallidum immunostain. That works the best. Your Giemsa stain or Wharton starry stain is generally not helpful. So treponema pallidum is an immunostain is what you would like to do, and it will stain the spirochete organisms, which are best illustrated at the dermoepidermal junction or within hair follicles. So you can see these nice curved organisms. These are all spirochete bacilli. So this is treponema pallidum infection, that is primary syphilis. Coming to your secondary syphilis. So secondary syphilis, we are going to judge it by your reaction patterns. Again, secondary syphilis is a great histologic and clinical mimicker. So it can masquerade as a lot of entities you may not think about. It can actually present with any kind of reaction pattern, but the most common reaction patterns that we see this are the ones that we're going to talk about. So again, you get a psoriasiform, sort of papillosquamous kind of an eruption with these elongated reedy ridges. So these elongated reedy ridges is a clue. If you go up on high power to the presence of the reedy ridges, you see that they kind of look dirty because there is an accompanying neutrophilic infiltrate. So you can see here these neutrophils, it's almost like they are broken down with a little bit of dust, and this makes the reedy ridges look dirty. So elongated reedy ridges with neutrophilic exocytosis. And then if you see in the dermis, you will see plasma cells. So you can see this nice collection of plasma cells in the dermis. So this pattern of plasma cells in the dermis with a psoriasiform irregular pattern with these elongated reedy ridges, and especially the neutrophils, the combination should definitely make you think about syphilis. So I call it kind of like a dirty reedy ridge pattern, neutrophils coming out, plasma cells in the dermis, and the reedy ridges which are elongated. So that's one pattern of secondary syphilis. Let's talk about a few more. This is the same pattern that we talked about. This is kind of psoriasiform and lichenoid. So you can see here a patchy kind of a lichenoid infiltrate, but then the same thing. You can see again here those same dirty looking reedy ridges, elongated. You can see the nice neutrophils pouring out of the vessels and plasma cells in the dermis. So again, this pattern should make you really think about secondary syphilis. So you can again see in here the same thing. You can see the neutrophils pouring out of the vessels in here. Sweetie ridges is kind of like a vaguely granulomatous infiltrate in the dermis with scattered plasma cells. You can see the nice plasma cells in here. So this again should make you think about secondary syphilis. What else? This is the reaction pattern of a tuberculoid granulomatous dermatitis. So remember when we talked about tuberculoid granulomas, these are these vertically oriented granulomas oriented perpendicular to the epidermis, growing around your follicular or vascular axis. And if the granulomas, if you go up on high power, and if they contain plasma cells, which is what you see in here, you can see numerous plasma cells, that again is very, very consistent with secondary syphilis. So you want to do a treponema pallidum immunostain on this slide to make sure that you're not seeing any spirochete organism. But this reaction pattern itself is very diagnostic of secondary syphilis. So again, tuberculoid granuloma. So we had the dirty, reedy, rich pattern. We have a tuberculoid granulomatous dermatitis pattern. This one is kind of a blurry, so I'm going to skip that. The next one. This is another common pattern. This is like a lupus-like pattern where you get a superficial deep perivascular lymphocytic infiltrate. So a tight lymphocytic infiltrate, but then when you go up on high power, you again see that this it's actually not just lymphocytes. There are a good number of plasma cells again in the infiltrate. So you can see here the nice plasma cells within the infiltrate. So lymphocytes with plasma cells. And then actually in this particular slide, the overlying reedy ridges are also elongated. So it has the same kind of a pattern. So superficial deep lymphocytic infiltrate with plasma cells should also make you think about secondary syphilis. Okay, let's see what more. So those are the different reaction patterns. So the most common ones that they like to test you on is the elongated reedy ridge with the dirty neutrophils. as well as plasma cells. The second one is a tuberculoid granulomatous dermatitis with plasma cells. And the third one is a superficial deep perivascular lymphocytic dermatitis with plasma cells. So all those are reaction patterns of secondary syphilis. Okay, now let's move on to your next infection. This particular infection, which we're going to talk about, is mycobacterial and atypical mycobacterial infection. This is again largely recognizable through the reaction pattern. So it produces you a suppurative granulomatous dermatitis with or without necrosis. Now, whenever we see a combination of neutrophils with granuloma, so you can see here numerous neutrophils, and in the background, you can see that there are lymphocytes and histiocytes. So a combination. So you see both acute and chronic inflammatory infiltrate in the form of neutrophils and giant cells. When you see that combination pattern, that should always make you worry about an infection. Now, in a typical scenario, if we encounter this in real life, we will stain up the slide. So we will do infectious stains like PAS, GMS, and for fungus, GRAM for bacteria, acid fast, and FIGHT for mycobacterial and atypical mycobacterial organisms. If the stains are negative, we would recommend culture. Now, in most instances, if it is a deep fungal infection, you can actually see the fungal organisms, but that may not, the organism may not be recognizable. In which case, we think about mycobacterial and atypical mycobacterial organisms. So what are the atypical we are talking about? So Burulli's ulcer, or your fish tank granuloma, Mycobacterium ulcerans, Mycobacterium marinum. Mycobacterium cheiloni and fortitum are the most common cause of skin infection following wound contamination. And then you have the rare ones like Mycobacterium kansasi, which is more common in lung and in the lymph nodes. So cheiloni, fortitum, marinum, and ulcerans are the more common ones. You cannot see these organisms. The only way to really diagnose them is to do culture. So you will recognize it with the reaction pattern. So if they give you a reaction pattern of suppurative granulomatous dermatitis like this, or like this in the next slide. So again, what do you see in here? You see a nice giant suppurative granuloma with central necrosis. This is very suggestive of mycobacterial infection. Central caseation necrosis and a suppurative granulomatous infiltrate in the background. So, you would recognize it from the reaction pattern. You cannot really see the organism. So only one of those mycobacterial or atypical mycobacterial organism would be the right answer, because there's no way of differentiating between all of them just based on histology. This was actually from a patient with mycobacterium with the fish tank, the swimming pool granuloma, Mycobacterium marinum infection. And you can see that the overlying epidermis shows exuberant pseudoepitheliomatous hyperplasia. You get the nice suppurative and the granulomatous infiltrate, and a FIGHT stain. I will show you the FIGHT stain. Basically demonstrated the mycobacterium. And these are the stains that we often have to be patient with. This particular one was easier to find, and you can see all these pink staining structures are your mycobacterial organisms. So that's Mycobacterium marinum infection, again recognizable just from the basis of your reaction pattern. Okay, so now let's go to the next infection. So we have two spectrum. We are talking about leprosy. The one end of the spectrum is lepromatous leprosy, and the other end of the spectrum is tuberculoid leprosy. So in lepromatous leprosy, the body has no immunity. So you will get a sheet of histiocytic infiltrate with stuffed up bacteria with minimal other inflammation. And in lepromatous leprosy, the organism load is so high that you do not even need to actually stain the slide. You can actually see the bacteria. It produces a reaction pattern with the Gren zone. And in the dermis, you get infiltration of histiocytic cells, which look like foamy cells. So it will produce on low power, like holes and spaces in the dermis, and you will not exactly know what you're dealing with. But then when you go up on high power, you can easily actually identify these clear cells, which will have these clusters of bacteria within them. So you don't even need to stain it. So all of this is a bunch of bacteria. This is one histiocyte, another one, another one, another one, another one, another one. You can see there are clumps of bacteria within them. These are called globoid cells. So globoid cells are seen in lepromatous leprosy, where you have infiltration of the dermis by histiocytic cells, which have engulfed this bacteria. So let's see another example. So again, even at this power, you can appreciate the beautiful Gren zone in this biopsy. So there's an uninvolved area of the dermis, And then when you go up on high power, there are all these sheets of histiocytes, and you can see the nice globoid cells with the clumped up bacteria within these histiocytic cells. So that is lepromatous leprosy. The other end of the spectrum is tuberculoid leprosy. This was another example of a patient. This was in between your lepromatous and tuberculoid. So borderline lepromatous leprosy or borderline tuberculoid leprosy. You can see that the body here has formed granulomas. So it has mounted a response, but at the same time, the bacterial load is easily recognizable. This is again a globoid cell. Now, they are not going to ask you to differentiate between different types of leprosy based on the slide, but you will need to recognize it as leprosy. This is a classic example of tuberculoid leprosy. So we can see the nice tuberculoid granulomas. Again, a bag of worms oriented perpendicular to the epidermis going around the neurovascular axis, expanded granulomas as in see in here. So the two things that you think about is tuberculoid leprosy and syphilis. In syphilis, these granulomas would have plasma cells. In the absence of plasma cells is largely with the reaction pattern that you will diagnose tuberculoid leprosy. Perineural inflammation will be common in tuberculoid leprosy. Now, the fight stain will not be able to detect the organism in this instance. In tuberculoid leprosy, you may get lucky, but it will require patience and thorough sectioning of the block and staining multiple levels to be able to detect maybe one bacteria. A more sensitive method would be to do PCR analysis. So PCR can detect the Mycobacterium leprae organisms. So this is tuberculoid leprosy. Okay, let's go to your next one. Next, a group of infections. So then now we have finished bacteria. Let's go to some parasites. So what is this an example of?
Is it scabies?
Yep. So burrowed beneath the stratum corneum, you see the nice scabies mite. So that's scabies. In the next example of it, we are going to see, you can see that there are multiple organisms in one section. So you can see one organism in here. You can see a bunch of organisms in here. So these are all scabies mites. So this is an example of Norwegian scabies. So you see multiple scabies mites in one sample of tissue. So that's Norwegian scabies. Demodex is different. Demodex mites like to live inside the hair follicles. They do not dig burrows beneath the stratum corneum like that. Another organism which likes to live in the stratum corneum is the one that I'm going to show you very soon. This is a nice example of a tick which is attached to the skin. It's an engorged tick. So this is just a tick bite. And sometimes we get intact pieces of skin like that. And it's nice to see this is the entire tick with the beautiful exoskeletal and its internal organs. And this is feeding off from the skin, as you can see in here. Okay, now coming to the ones that live in the stratum corneum. So this particular patient, has history of traveling to Florida and then walking bare feet in the sand, which was quite hot and humid. And he subsequently develops a creeping eruption. So this is your cutaneous lava migrans. So the organism, which is Ankylostoma brasiliensis, is going to be seen right beneath the stratum corneum. So it has penetrated the skin, whereas scabies burrows a mite just in the stratum corneum. This likes to live deeper in the skin. The background you can see looks like dishydrosis. So it will incite an eczematous response with lots of eosinophils. So you will see lots of eosinophils. So remember, that's where ankylostoma or creeping eruption likes to live. It's right beneath the stratum corneum. And this is where you will find the organism. So this is cutaneous lava migrans. Okay. This one is an example of, so you can see that there is a large burrow that has been dug into the skin. And within this burrow, you can see all these larvae and maggots form living. So this is cutaneous myiasis. So you can see all these larvae and maggots form living in the burrow inside the skin. That's cutaneous myiasis. Hold on 1 minute, guys. Just need to answer this. Give me 1 minute. So in the meantime, let me just, I'm going to share this. Hey, John, the patient that you spoke about in the morning with me about that one with the alopecia with the no specimen, what was the patient's name?
It is, just get the record still down here. Lindsay Anderson.
Okay, thank you.
You're welcome.
Bye.
Okay,
Bye.
bye.
Okay, so I wanted to show you, and I'm going to share this presentation with you guys later, but we just wanted as a comparison. So here, this is myiasis. So you see a burrow with cutaneous larva and maggots dug inside the skin. Now, distinguish this from tungiasis or tunga penetrans, where a gravid flea communicates with the stratum corneum. This is again a pregnant flea. So you will see this. So you will see some kind of a communication within the epidermis, but this looks different from myiasis. So keep that in common. This is again a nice board question that they like to ask you. That's tungiasis or tunga penetrans. And this, on the other hand, is myiasis. Okay, let's go to our next case. Now we're going to talk about some fungal infections. One more thing. So the things that the big things that try to live in the skin. So myiasis, tungiasis, tunga penetrans, onchocerca infection, which produces your leopard skin. So that will produce these microfilarial worms in the skin. So they actually look like tiny worms. Cysticercosis is another one that they may like to ask you. That's a tinea solium infection, but that's actually the tapeworm, which often is surrounded by this dense fibrotic response. So they all look different. So you may want to go to the PowerPoint slide and look at all these organisms just to remember how they look like. Okay, so let's go to your superficial dermatophytosis or tinea infection. Now, this likes to produce what we know as a sandwich sign. So you always get dirty neutrophils in the cornified layer in the stratum corneum, and you just have to dive into where you think would be the most high yield, where the most infection is, and fungal organisms appear as translucent holes and spaces in the stratum corneum. So you can see that these are the organisms in there. You may see them as tiny empty holes also in the stratum corneum. So that is a tinea infection. There is more in here. These are obviously much more easily recognizable on your PAS stain. But most of the time, you will not have a PAS stain on your board. So you will need to recognize it like this. You can see these holes and spaces. You guys see that?
Yeah.
That's another one right there. So that's tinea infection. So subcorneal blister or dirty neutrophils in the stratum corneum is what makes you think about it. It's another example. So you can again see a busy stratum corneum. And you can see that there are numerous fungal organisms, all these holes and spaces. You can see many of them in here. And so that's tinea infection. Okay. The next one we are going to talk about is, let's go to a slide. Okay, so this is a type of tinea which doesn't incite much inflammatory response. It will be invisible dermatosis going from the top to the bottom. You do not see much happening in the skin. And if you go up on high power, you actually see that they are blue spores and hyphae in the cornified layer. So this is, what is the diagnosis here?
Tinea versicolor?
Yep, so that's tinea versicolor. Your malassezia fervor, which doesn't incite inflammatory response. It's an invisible dermatosis, but when you go in the stratum corneum, you see the fungal organisms. So good. Let's go on to your next one. The next is also Okay, so this one clinically often may look like a pigmented lesion. So on the stratum corneum, but when you go up on high power, you actually see these pigmented fungal hyphae in the stratum corneum. So this is tinea nigra. So clinically, this often comes to us as a pigmented lesion, and it's not. And you can see the nice, the tinea organisms in the stratum corneum. So that is tinea nigra. Okay, the next one. Okay, so this is more recognizing what this is. Both Miyawki's granuloma and tinea capitis would look like this. If you've not seen it, it's easy to blow off the infected fungal hair shafts, the infected fungal hair shafts. So this is a nice hair shaft in here, and you can actually see that it is being completely destroyed by these fungal organisms. So this if incites a deeper suppurative response with it will produce you a deeper nodular abscess, which will be Miyawki's granuloma. But both tinea capitis and Miyawki's granuloma, they look the same. So you can see these infected hair shafts, these fungal spores and hyphae. So I'm going to show you some examples of it because I want you to remember this is how your endothrix would also look like. So again, you can see nice deep punch biopsy. And this is again is the infected hair shaft. So you can see in here. More example of it. You may need to look at all the levels. If you've not seen it, this may look really weird and you may try to blow it off, but this is again a pigmented hair shaft with the fungal organisms within it. This is another example of it. This is from the hair, the scalp biopsy. You see numerous hair shafts. And again, you can see these nice organisms within the hair shaft. You can see in here. That's tinea capitis. Okay, let's go to our next one. Now, this particular infection, it incites a lot of inflammatory response. The inflammatory response can be lichenoid, or it can also produce you a lot of reactive epithelial hyperplasia. But if you pay attention to the stratum corneum, you can see that these are all pseudohyphae and spores, which are like in a jabbed pattern. They are perpendicular to the epidermis. So that's your Candida infection. So you can see all these perpendicular oriented spores and pseudohyphae. So that's your candidiasis. So they look like tinea versicolor because you can see them. The difference is they're perpendicular oriented and they incite a lot of inflammatory response. So I'll show you more examples. So this is another example. So here you can see how densely inflamed it looks. It looks like lichenoid, lots of purulent inflammation. And you can see the nice organisms in here. So you can see the spores on the top and these pseudohyphae oriented perpendicular to the epidermis. So that's Candida infection. Let's see more examples of it. This one again has incited a dense lichenoid response. It can mimic mucosal lichen planus, but again in the stratum corneum, you basically see these nice spores and these hyphae which are oriented perpendicular. So that's candidiasis in there. Okay. Here, this is not uncommon that Candida infection can incite a lot of pseudoepitheliomatous hyperplasia, and I've seen lesions on the lip being overinterpreted as cancer. So you can see how it has incited epithelial hyperplasia with atypia, which is all reactive. Because if you look up again in the stratum corneum, you can see that there is like a party of Candida in here. So these are all spores and hyphae. That's candidiasis again. Okay, now let's go to your other category of fungal infections. So this was largely superficial fungal infection. Now, when you come into the deep fungal infection category, you like to classify them as pigmented or non-pigmented. If it's pigmented fungus, it comes in the category of dematiaceous fungus, which brings you to the top three most common fungi, which are pheohyphomycosis, chromoblastomycosis, and alternariosis. Alternariosis and pheohyphomycosis look similar, except that alternariosis exclusively occurs in immunocompromised individuals. So you'll have a history of like a sick patient in the hospital, immunocompromised, having received a recent stem cell transplantation, something like that, neutropenic patients. If it's non-pigmented, then you come in the category of mucor or largely aspergillus and fusariosis. And we'll talk about penicillosis later. But mucor, fusariosis, and aspergillosis, these are non-pigmented hyphae and spores. So we'll talk about all of them. So if it's pigmented, it's dematiaceous fungus, which could be pheohypho, chromo, or alternaria infection. So dematiaceous fungus commonly occur at the site of trauma. So you may see evidence of that from scar and hemorrhage and chronic blood and hemosiderin. But then amongst all that inflammatory infiltrate, you see these are pigmented hyphae and spores. So this is pheohyphomycosis occurring at the site of trauma in here. Let me show you more examples. Very often they accompany a splinter. So it's not uncommon that you will actually see a splinter. So you can see the nice splinter in here. And this is superimposed is the pheohyphomycosis. Splinter-associated pheohyphomycosis can be excised because if you take the foreign body out and if the organism has not spilled over into the tissue or excise around it, you get rid of the infection. This is not uncommon that it follows a plant material with it, contaminated plant material. They may form like a mass lesion and the patient may forget about it. But then when you take a biopsy, you obviously see this nice suppurative granuloma. And within it, you don't even need to stain it, but you see the nice pigmented hyphae. So that's all pheohyphomycosis. You can see the numerous pigmented fungal hyphae in here. So this is pheohyphomycosis. So this probably formed a lesion, which is clinically mimicking a squamous or a basal cell. This is another example. So you can see the nice suppurative granuloma. So, this obviously makes you think about an infection and you would jump right into it. And, if you're lucky, you will get right away lucky as you'll be able to pick up the organism. Pheo is easy because you can easily see it. So, you just have to be patient with the biopsy. Let me get back into it again, 45. So you have to be patient with it, just jump right into the biopsy and you can see all these pigmented fungal hyphae in there. So that's all pheohyphomycosis. There are actually quite a few. You can see this in the giant cell itself in here. This is pheohyphomycosis. This is how exactly alternariosis will also look like. So alternaria or pheohyphomycosis will produce the suppurative granulomatous response with these pigmented fungal hyphae. The next one, which is your chromoblastomycosis, is this is another example of pheo. So this was on the ankle of the patient and clinically came in as again a malignancy, but you can see that amidst the suppurative and I will talk about that tomorrow. Yeah. And amidst the suppurative granulomatous infiltrate, you can see these nice pigmented fungal hyphae, and that's all pheohyphomycosis again. So I'm showing you multiple examples because these are the most common both testable entities. Chromo is easy to recognize. It's notorious for inciting lots of pseudoepitheliomatous hyperplasia. So lots of squamous cell-like hyperplasia, and present amidst the infiltrate are the nice copper penny or medlar body. So you can see these nice collections of pigmented spores, which are many of these are even budding. The beautiful copper penny body. So that's chromoblastomycosis. Okay. This is an example, on the other hand, typically these lesions produce cutaneous infarction. And what you see among all that hemorrhage and infarcted tissue are these organisms, which are clearly hyphae, but they are broad ribbon-like, and they are aseptate, and they are not pigmented. So this is again a deep fungal infection, which is ribbon-like, but it's not pigmented and aseptate. And it has an obtuse angle branching. So it's a broad angle branching. So this is mucormycosis. And mucor can be absidia or rhizopus. Mucormycosis can be mucor, absidia, or rhizopus. You cannot distinguish them. For mucormycosis, so you have these ribbon-like structures which are aseptate with the broad branching, and they're not pigmented. On the other hand, aspergillus or fusariosis, they will look exactly similar. So aspergillus and fusariosis, they will produce you a slender hyphae, which are not pigmented, which are septate, and they have an acute angle branching. So that's aspergillus, and this is fusariosis. You can see the slender septate with an acute angle branching. So that's fusariosis. Okay, let's go to our next one. Okay, so now we are going to be talking about deep fungal organisms and the size matter. So we have to kind of memorize this based on the size of the organism. So how do we go by the size? Okay, so I should have a slide somewhere in here which talks about the size. So hold on 1 minute. Okay, so this is the size that we will go by. So the first one is Leishmania and Histo, which are similar in size, and Penicilliosis, which looks exactly like Histo and Leishmania, more so like histoplasmosis. So these are all similar in size. The next one is Cryptococcosis. The next one is Blasto, which is equal in size to Lobo. And then we have Coccidio and Paracoccidiomycosis. These are the size that you, if you want to take a picture of the slide, you know, for memorization, you will need to remember it like that. So let's go to our first slide. So this is a nice deep suppurative granulomatous inflammatory infiltrate, and if you see any of those organisms, the only way is jump right into it. And when you jump right into it, you will see that many of these are referred to as parasitized histiocytes. So you can see that they are all histiocytes which are stuffed up with these organisms. So you can notice all these organisms inside these histiocytes. Now, this could be Leishmania or this could be Histo. Now, how do you differentiate between Leishmania from Histo is that Histo is capsulated. So histoplasma capsulated, so it will have a capsule around it, whereas Leishmania will not. So many of these, they look like they have empty spaces around them. So that is a capsule. So this is histoplasmosis. So if you can appreciate a capsule, as you can see in here, many of them have spaces around them. That's histoplasmosis. Now, this is how exactly penicilliosis will also look like. The difference for penicilliosis will be again a specific history. So a neutropenic, sick patient, hospital-based setting. Again, a dense suppurative inflammatory infiltrate, and you just have to again jump right into it. And what we again see are these organisms which are inside the histiocytes. But now they are attached more to the histiocytic wall like the spokes of a wheel, and they lack the capsule. This is Leishmania. So it likes to be attached to the histiocytic wall. They often have differential staining because of the kinetoplast. So that has a safety pin appearance. So one end looks darker than the other. But honestly, it can be very challenging to recognize the difference. These look like little safety pins, as you can see in here, but they lack the capsule. The capsule is the most recognizable and the prominent feature. So that is Leishmania, as you can see in here. So histoleishmania and penicilliosis will all be similar size. The next one we're going to talk about is cryptococcosis. So cryptococcosis is a little unusual because unlike the others, it does not incite a suppurative granulomatous response. It incites more of a gelatinous, foamy response. So what you see is a biopsy which doesn't look that inflamed. It actually looks like it has empty spaces and vacuoles. But when you go up on high power, you can clearly see the organisms. These organisms, many of them have a cup-shaped morphology. They look like little canoe boats. They are often encapsulated and have mucin. So they will be positive for mucicarbon. That's what produces those pools of mucin. So within these vacuolated spaces, you can see nicely these cup-shaped structures like this, many of which are also budding, but it is significantly bigger in size as compared to Histo and Leishmania. So this is all your cryptococcosis. Another organism which produces these kind of cup-shaped canoe structures is pneumocystitis, pneumocystosis carinii. That is an AIDS-defining illness, very rare in the skin. Rare cases have occurred, infection of the ear producing that, but most commonly it's the infection in the lungs. It can look very similar to crypto, so remember that. That's pneumocystitis carinii, which is your AIDS-defining illness. Okay, guys, give me a minute. So this is your nice cryptoorganisms, pools of mucin, and you can see these budding structures in there. Remember, pneumocystitis will look similar to this. The next organism based upon the size is your blastomycosis. So blastomycosis incites a lot of inflammatory response with pseudoepithelomatous hyperplasia and dense suppurative granulomatous inflammation. And what you see in here are the structures which are bigger than crypto, and they look like your little eggs, spherules like this. They're broad-based and will often bud. So these refractile buds and these encapsulated organisms, as you can see in here. So that is blastomycosis. Now, blastomycosis is one organism which can also get extruded out in the crust. So one of the places where people forget to look for blasto is in the crust. You can see that this was an infection and it incited a lot of reactive pseudoepithelomatous hyperplasia. There is thick epidermis. There is lots of serum and crust being extruded out. And that's the place where you would like to look for this organism. And within the extruded serum and crust, you actually see these organisms. You can see them producing these empty halos. This is a bud right here. So this is all blasto. So blastomycosis. So don't forget that you want to look in the serum and crust as well. Lobomycosis is going to be very similar to blasto. The difference is that lobomycosis likes to form long chain spherules and tubules. So let's see an example of lobo. Okay, so everybody knows about the infection with the bottlenose dolphin. So those can be the natural habitat of these organisms. And what you see in here is this long chains of spherical cells connected by tubules. So background of keloidal scarring. So it's the same size of the organism, except that they are connected to form these long size tubules. So that's your blastomycosis. Lobomycosis. So that's blasto right there. The next one we're going to talk in size is your coccidio. So coccidiomycosis are also pretty easily visible, significantly bigger than blasto. It again incites a lot of pseudoepithelomatous hyperplasia, as you can see in over here. And amidst this inflammatory infiltrate, you will see big, again, structures which really look like eggs. So thick wall spherules filled with endospores. So it's right in here. So you can see this nice structure. It is a spherule filled with endospores. So that's coccidiomycosis. Paracoccidiomycosis is the same size, except that many of the spores are attached on the outer side. I've never seen paracoccidiomycosis. Very often, they in the biopsy may look like coccidio, but the classic appearance of paracoccidiomycosis is that Mariner's cartwheel appearance. So let's see paracoccidiomycosis. So you can see these structures right in here. They look almost like coccidios. They'll have to give you another specific order question or to show you a PAS or a GMS stain with it. You can see the nice spherules attached to the nice buds attached to the spherules outside. This is your Pallet's wheel appearance of paracoccidiomycosis. Okay. Do you guys have any questions till now?
No, I don't think so.
Okay. Then let's go on into your viral infections. This is an easily recognizable infection, that is your molluscum. Pox virus infection. These are large viruses that live in the cytoplasm, produce your classic Henderson-Patterson bodies, which are your intracytoplasmic pink inclusions. Another recognizable feature of this infection is the bulbous pink epithelial islands. So sometimes when we are not getting into the block, but when we see this eosinophilic bulbous epithelial structures, we may think about molluscum pretty readily because of these. So, but you can easily see the intracytoplasmic pink inclusions in here. So that's your molluscum. Another pox virus infection that they like to ask is the one we will talk about very soon. But let's talk about your common wart, verruca infection. So this is your HPV-driven verruca vulgaris, produces a nice verrucous epithelial hyperplasia with these nice papillomatosis, finger-like projections. And you can see the nice hyperkeratosis and hypergranulosis with these intracytoplasmic, these intranuclear viral particles, which look like dense keratohyalin granules, but they're all actually viral inclusions. Produce the coilocytes with these empty spaces around the nuclei. So that's your nice verruca vulgaris. Again, in the shared PowerPoint in here, you should know about the different the HPV infections in all different kinds of warts and the ones associated with the high-risk malignancies. So the high-risk HPV, so we'll talk about that. So but the HPV type should be very well known if you guys already don't know it, which I'm pretty sure you do. This is your myromycial wart or palmoplanta verruca. So this, besides producing the blue, will also produce you the pink inclusions. So it has a cup-shaped morphology with lots of hyperkeratosis. And then you can see the cytoplasmic inclusions, which are blue and pink. Now, this, if you're not paying attention on low power, this slide can look like EHK, epidermolytic hyperkeratosis. So make sure that in EHK, epidermolytic hyperkeratosis, you also get prominent keratohyalin granules, but those are not viral inclusions. And there you get pallor of the stratum spinosum because of the cytoplasmic dissolution of keratin filaments. So you get clumped pink inclusions inside the cells. This is a different process and different kind of inclusions, and you don't get the pallor in this. So this is your palmoplanta verruca, HPV 1 and 2. The next one is your verruca plana. So in verruca plana, instead of getting papillomatosis, you get a flat lesion, but you get the same thing. These are called the fish eyes. You get hypergranulosis, and you get the nice coilocytes, but they are present in a flat pattern in the superficial epidermis. So that's verruca plana. Again, this is a very commonly asked question. Epidermodysplasia verruciformis, which is associated with progression to squamous cells. What HPV is that?
5 and 8.
Yep. So you can see this nice collection of keratinocytes, which will have the pale blue gray cytoplasm, steel gray cytoplasm in the superficial epidermis. Obviously, these lesions are at risk of progression to Bowen's disease. Very often within the same field, we may also see adjacent squamous cell carcinoma, so it's not uncommon. But this is beautiful epidermodysplasia verruciformis. Next one is your condyloma. So condyloma acuminatum, which is your HPV infection, which could be low risk or high risk. The low risk is 6 and 11, high risk is 16, 18, 31, and 32. Just by looking at the slide, if you don't have existing squamous cell, you cannot type it. You cannot say which HPV type it is. For that, you need to do either PCR or in situ hybridization. Classically, these lesions on low power will look either like a tag or will look like a seborrheic keratosis. So they mimic a tag or a sepke. But when you go on high power, you can see that there is quite a lot of papillomatosis in a flat pattern. And when you can see the nice coilocytes, which have got racinoid nuclei. So you can see these clumped nuclei with perinuclear halos. But this is all HPV-mediated genital HPV condyloma. If there is associated squamous cell carcinoma, Bowen's disease with it, then it's obviously high-risk HPV, 16, 18, 31, and 32. another example of a condyloma. So this looks like, that looked like a tag. This looks like a sepke. But when you go on high power, you can easily see this is not a sepke. You can see the nice viral inclusions with these racinoid nuclei. That's again a condyloma. Okay, this is the infection we have talked about quite a lot. So what is the diagnosis here? So what's the reaction pattern here?
Spongiosis.
So this is ballooning reticular degeneration. Yep. So, and what is a virus that does that? The two viruses that do that, or three viruses?
Hand, foot, and mouth.
So Coxsackie, hand, foot, and mouth, but most often when they're testing you, they're asking for ORF. So ORF or ecthyma contagiosum, which is your parapox virus infection, and a Milker's nodule. And then monkeypox can also do this ballooning reticular degeneration. So you get this spongiosis with ballooning degeneration of the keratinocytes. You don't really see the viral inclusions, but you recognize it based upon the reaction pattern. So hand, foot, and mouth, which is Coxsackie virus, or for ecthyma contagiosum and Milker's nodule, and monkeypox virus can do this. Okay. This is another virus which produces a lot of inflammatory response, often a superficial deep inflammatory infiltrate. And you get these classic viral cytopathic change, which is the 3 M's, which is multinucleation, molding, and margination of chromatin. So you can see this beautiful herpetic inclusion. So this is herpes simplex virus. HSV1, HSV2, varicella, chickenpox, zoster, shingles can all give this reaction pattern. So you cannot differentiate them by just looking at the slide. You see the 3 M's, the multinucleation, molding, and margination of chromatin. So that is herpes virus infection. These slides can look really busy. They can, this one didn't scan out well. Show you. So, you know, lots of erosion and crust. You can see the nice ulcer. And within the ulcer bed, let's see, where are you seeing the, oh, here. So you can see the nice, this is almost like a Zang smear. You can see the nice margination and the multinucleation. So these are beautiful virally infected cells. So that's herpetic ulcer. Okay. This is not an uncommon scenario where you see suppuration and abscess formation. So again, the slide did not slide well. Let me do the repeat. Okay. So you see this, all this suppuration and abscess. This is just nothing but necrosis and tons of neutrophils. And along with this, you again see these ball of fungus, many of which are pigmented. So when you see the triad of suppuration and abscess and organisms, it is what is characteristic of a sulfur granule, so draining sinuses. So they can ask you a bunch of questions based on that. And I'm going to quickly go through the PowerPoint illustration of that, because you can be asked questions. So let me open that up. Okay, so mycetoma. So that's a triad of an abscess, draining sinus, and grains and granules in the exudate. That can be caused by either filamentous bacteria, which most common is your nocardia and actinomadura, but most often it is caused by fungus. And this is a very important question, Madura mycotic mycetoma. So that was the example. The slide that I showed you was this particular organism. The color of the granules being discharged from the sinus will often help you to determine. So this is another slide that you need to memorize. So if it's red grains, it's actinomadura. Black, which is the most common, is madurella, which is what, again, that infection was. If it's brown, it's I cannot even pronounce these, but you will need to learn this. So mycetoma is a fungal ball. It's not a fungal ball, but it is a triad of suppuration, abscess, and granules. And those granules can be either fungal or bacterial. The bacteria is most common, your nocardia or actinomadura, and the fungus most common is your Madurella mycetomatis. So you need to memorize that. And that's how the histology would look like. Some of the other uncommon infections which I did not cover is what they like to ask you is actinomycosis. This produce these are gram-positive bacteria, and they produce these again club-shaped structures. This is a classic slide for actinomycosis. And they can ask you the difference between nocardia and actinomycosis. Both of these are gram-positive filamentous bacteria. One is acid-fast positive, and this is acid-fast negative. And then you should know the kind of infections that they can cause. I'm going to definitely share this PowerPoint at the end of the talk. As far as the slides are concerned, I'm done. But there are some high yield questions that can be asked in there. For example, bacillary angiomatosis. So there's a slide in here of bacillary angiomatosis, which, during the AIDS era was a very prevalent infection, which was caused by your Bartonella Hensley infection. And it looks like a pyogenic granuloma, but it has clumps of amphiphilic bacteria in there. So let's book up bacillary. Yeah. So bacillary angiomatosis, it looks like a pyogenic granuloma, but when you go up on high power, it has these clumps of bacteria in there, this blue staining bacteria. So that's caused by Bartonella Hensley, which is the same organism which produces your cat scratch disease. One of the nice terminology they like to use for cat scratch disease, which is also caused by Bartonella Hensley, is stellate necrosis. So you will get a suppurated granuloma in the dermis with the stellate kind of a necrosis. That's like a buzzword in case if they like to ask you. As far as your sexually transmitted diseases are concerned, there are two: Haemophilus ducreyi, which produces your soft chancre, and a lymphogranuloma venereum, which is produced by Chlamydia trachomatis. And there is something about these organisms that they like to ask you. Yeah, one thing which I forgot to tell is sporotrichosis. Let me just briefly go to sporotrichosis. So sporotrichosis, is actually not an uncommon infection that we may deal with. Sporo. Okay, so everybody knows about the lymphatic distribution in a linear pattern. This particular infection, it produces you the classic zonation pattern. So abscess with neutrophils, then granulation tissue and granulomas. The other organism which does that is your chancroid, your Haemophilus ducreyi, which is a sexually transmitted disease. So these are the two organisms which can produce you this reaction pattern. Now, sporotrichosis is very easy to culture, however, very difficult to see. I have never ever seen it. I've suspected it, but never seen it. It produces, there are certain buzzwords you think about when you want to detect sporotrichosis: asteroid bodies. So you see this kind of an asteroid body phenomenon, which is like a Splendor-Hopley phenomenon when there is sporotrichosis infection. It's very easy to culture and produces this cigar-shaped yeast. And that is how it is supposed to look in the tissue as well. So a PS or a GMS stain is going to show these cigar-shaped structures. That's sporotrichosis. But it's extremely difficult to visualize. So they will either have to give you a second order question or show you a PS or a GMS stain, which will look like this, show you a culture, which will look like this, the cigar-shaped yeast, or give you some buzzwords or a clinical history with it. Another thing which I would like to talk about, which has actually come up in your core boards, is rhinosporidiosis. So rhinosporidiosis is an infection in India and Sri Lanka, which is actually a waterborne infection. So it is a nasopharyngeal infection, which is produced by Rhinosporidium seaburi. Now, they can give you a high power view of this, and this looks like they try to throw in coccidiomycosis in there. Coccidiomycosis is much, much smaller. These sporangia filled with spores are very easily visible on low power, like 4x or 10x. Whereas coccidio, you will definitely need to go on 40x at least to see the organism. So even though a blown out picture may look the same, they're actually really different. So remember rhinosporidiosis and coccidiomycosis, you know, in case if you're getting confused. I think that is about what I wanted to talk about in infectious diseases with you all. Is there any questions that you guys have?
I don't think so.
Okay, so I'm going to share this PowerPoint with you, and I'll also share those slides with you, and you can go through and revise your infectious organisms. So if you have any questions, please, you know, get in touch with me, and I will share this recorded PowerPoint because I know a number of people are missing today. And do urge them to go through the I'm going to share my presentation and the recording.
Perfect. Thank you so much.
Thank you. Well, you
Thank-
guys have a good evening.
You too.
Thank
Bye.
you, you too.
Thank you. Bye.